My name is Dr. Michael Jaff, and I'm pleased to be with you today to discuss the cost effectiveness of the management of arterial dissections following angioplasty in femoropopliteal peripheral artery disease. As you know, angioplasty has been a mainstay endovascular treatment for patients with peripheral artery disease. However, there are a number of complications and limitations of angioplasty, not the least of which is the formation of arterial dissections at the time of the procedure. That, in fact, is the inherent mechanism of action of angioplasty. The frequency can occur in almost 85% of all angioplasties in the superficial femoral artery, and about half of these can be severe and flow limiting and have to be managed at the time of the procedure. However, that means that the other half are not even identified or not considered serious or flow limiting, and yet they can have serious implications for durability of the endovascular procedure. Most patients require some other adjuvant therapy to manage their dissection. The Tack Endovascular System is a novel device that specifically addresses dissections following angioplasty. It's a durable, minimally invasive, low amount of metal technology that manages the dissection very simply and provides durability for the procedure. It's US FDA approved. There are multiple self-sizing implants that are in one system. And as I mentioned, these devices leave a very small metal footprint as compared to self-expanding nitinol stents. There have been a whole host of clinical trials that have studied the role of the Tack implant system in patients with peripheral artery disease, and over 550 patients have been studied in above-the-knee interventions for PAD. The goal of this study is to demonstrate the cost-effectiveness of using the Tack endovascular implant system to manage dissections after angioplasty for peripheral artery disease. In the series that we will be discussing, we looked at all dissections: non-severe, those are types A and B, and severe, type C or greater, to look at the impact and the cost of these interventions. We used a decision analytic model with a 24-month time horizon based on data from the TOBA-2 angioplasty cohort that was extrapolated out to 24 months. We did a comparator study looking at A and B dissections matching to PTA alone, and C or greater dissections that looked at a meta-analysis of bare metal stent performance and, in fact, drug-eluting stent trial data. Looking at cost, we used the US Medicare fee schedule, and we did device costs based on the average selling price of the Tack device. We then calculated quality-adjusted life years using TLR-associated quality-adjusted life year decrement. The healthcare economic analysis looked at the index procedure costs, 24-month reintervention rates, and the estimated incremental cost-effectiveness analysis. Let's start off by looking at the non-severe type A and B dissections. Just to orient you to this slide, the dark blue color looks at the index procedure costs of the devices. The medium blue color looks at all of the other procedural costs. And then the red bar looks at reintervention costs out to 24 months. And you can see in these non-severe dissection groups, if you were treated with angioplasty alone, the initial cost is less expensive than the Tack, and that's obvious because the Tack has a cost associated with it. However, if you look at the 24-month target lesion revascularization rate, there is a marked reduction in TLR rates, over 25%, if the Tack device is used compared to PTA alone. That higher index cost is largely amortized by reducing the reintervention cost, resulting in a $97,000 reduction in the quality-adjusted life year gained, and that is viewed by virtually every cost-effectiveness analysis as cost-effective. And in this scenario, you'll notice that the stent-based therapy is more expensive, over $1,000 more expensive than the Tack therapy. But most importantly in this group, you can see a reduction in the target lesion revascularization rates with the Tack device compared to stent-based therapy. So not only is there an advantage on the index procedure, but there's an advantage in a reduction in TLR rates. And this results in a Tack-dominant strategy that looks to show a real advantage from a cost-effectiveness standpoint. Now, let's put all of this together, looking at A and B dissections and C or greater dissections. Same color scheme, again comparing the standard of care or the status quo left up to the interventionists. It appears that there's a slightly higher cost to the status quo compared to tack-based therapy. But most impressively, look at the reduction in target lesion revascularization rates when you use a tack-based therapy as compared to the standard of care. This is a real reduction with a minor increase in 24-month cost. And this gives you a total concurrent cost savings that again supports tack as the initial management for virtually any arterial dissection. So in conclusion, untreated dissections of all severity, minimal A and B, severe C or greater, lead to suboptimal outcomes and ultimately a cost economic burden to society. The management of post-angioplasty dissections using the Tack Endovascular System improves clinical outcomes, reduces target lesion revascularization rates, and now has demonstrated cost effectiveness and possibly cost savings out to 24 months. Information about dissection grade specific outcomes of comparative approaches are limited, and that's an opportunity for further study prospectively. So the next steps, let's look at the cost effectiveness analysis of the tack system in infrapopliteal arteries, an area in which cost is greater with critical limb ischemia as the predominant clinical syndrome.